Part 7. The Palliative Care Hijac. How Preventable Decline is Being Framed as End of Life. By Canadian Citizens Journal. Palliative care was meant to protect people. Now it is being used to redirect them. Palliative care in Canada was originally built on a simple principle. When a person is approaching the natural end of life, their comfort becomes the priority. But inside long-term care homes, especially after 2020, the meaning of palliative care has shifted. Residents are increasingly being classified as palliative not because they are dying, but because the system cannot provide the level of care needed to keep them stable. When chronic understaffing, poor nutrition, unaddressed infections, environmental neglect, and delayed medical intervention push a resident into rapid decline, the system now calls that decline end of life. This shift is the foundation of the palliative care hijac. The new pipeline from decline, palliative, made. The same pattern is seen across long-term care facilities throughout Canada. Families are told their loved one is failing to thrive. Workers are told there is nothing more that can be done. Charts describe the decline as irreversible. But in many cases, the suffering that leads to the palliative label is produced by understaffing, rushed or unsafe feeding, lack of proper hydration, preventable infections, inadequate mobility support, cold rooms, environmental hazards, delayed medication adjustments, untreated pain, emotional isolation. When a system creates decline and then labels that decline palliative, it becomes a funnel, and the end of that funnel intersects directly with MAID. The collapse of clinical staffing, when nurses are overloaded and personal support workers carry the weight. One of the strongest drivers of premature palliative classification is the collapse of clinical staffing inside long-term care. In many facilities, one nurse is responsible for all medications, charting and assessments, contacting physicians, emergency responses, multiple floors or buildings, supervising all personal support workers, handling unstable medical conditions, managing behaviors and crises, care plans, referrals, and paperwork. No nurse can safely manage this workload. The system knows it, yet nothing changes. The coverage personal support worker, one worker doing the job of two buildings. To compensate for impossible nurse workloads, many facilities rely on a single multi-building personal support worker who is required to fill every gap. This worker is expected to, in one building, assist with feeding and baths, respond to all call bells, manage behaviors, answer emergencies, then move to the other building, finish medication support, answer additional call bells, assist residents with mobility, help the overwhelmed nurse, cover personal care shortfalls. This position effectively becomes extra care staff, extra medication staff, behavioral support, medical backup, emergency response. It is unsafe by design, and yet it has become normalized inside long-term care. When the nurse calls in sick, the entire system collapses. If the only nurse on duty calls in sick, the medical workload falls onto personal support workers who are already stretched to their limits. They are then expected to handle personal care, call responses, feeding, emergencies, medication passes, supervision of confused or high-needs residents. Personal support workers are not trained or licensed to interpret new medications, manage drug interactions, evaluate medical instability, triage multiple crises, respond to acute medical emergencies. Under these circumstances, medication errors are inevitable, especially after dose adjustments, new prescriptions, or complex behavioral medication changes. The errors are not caused by workers. They are caused by a system using unlicensed staff as emergency replacement nurses. Chronic stress, the emotional weight workers carry. Inside long-term care, workers live with constant emotional and moral pressure. They carry fear of missing critical medications, fear of residents falling, guilt from not having enough time, exhaustion from double workloads, emotional trauma from preventable suffering, burnout so severe it forces people out of the field. This is not a workplace challenge. It is a daily emergency affecting an entire sector. How staffing collapse leads to premature palliative labeling. When staffing is unstable or unsafe, residents do not receive early assessments, timely medication changes, hydration support, safe feeding, behavioral monitoring, wound care, mobility assistance, prompt medical evaluation. Preventable decline accumulates. Eventually, charts begin describing the resident as palliative, not because they are naturally dying, but because they were never given the support needed to remain stable. The system did not run out of treatments. The system ran out of staff. Palliative care used to mean comfort, Now it often means we cannot manage care. Workers across long-term care homes describe residents being placed on palliative pathways for reasons that are entirely preventable. Weight loss caused by unsafe food, dehydration from low staffing, infections that went untreated too long, weakness from chronic understaffing, mobility decline from lack of support, emotional withdrawal due to isolation, failure to monitor mental decline, residents kept in cold rooms, improper nutrition. These are not natural indicators of end of life. They are the result of decline created by the system itself. Once a resident is labeled palliative, MAID conversations begin. Once the palliative label appears, a new narrative begins. Families who never considered medically assisted death are introduced to it. Families who refuse are pressured to hear about it. Workers are instructed to provide information. Residents internalize the idea that they are a burden. The sequence is predictable. System neglect, preventable decline, palliative label, MAID eligibility. Palliative care has been hijacked. Palliative care was meant to bring peace, dignity, and compassion at the true end of life. Today, it is being used as a management tool inside a collapsing long-term care system. This chapter exposes what families and workers have quietly suspected for years. Palliative care is no longer reserved for those genuinely dying. It is increasingly being used to categorize those the system no longer has the capacity to support, and it feeds directly into the path toward MAID.